We'll be doing dilated cardiomyopathy, and we're going to look at the large group of disorders that can give rise to a dilated cardiomyopathy. And the name, as the name says, dilated cardiomyopathy, the heart is big. And it's usually, we should sort of reclassify it as idiopathic. That is, initially we don't know what's causing it, but there's a lot of possibilities, and we need to know the different groups because they're treated differently. So broadly, when we talk about a dilated cardiomyopathy, it's a large group of heterogeneous myocardial disorders characterized by ventricular dilation. So the ventricle is dilated, and the atria can be dilated as well, but not necessarily. You have depressed myocardial contractility, so that the heart is not pumping strong, ejection fraction is reduced. And in the absence of obvious cause, such as valvular disease, hypertension. So initially, we don't know. We can treat these patients, depending on the ejection fraction and stuff. After we treat them, or during the process of treating them, we should try and find out what's causing it. So this is, if this is what the normal heart looks like, so the left ventricle, the right ventricle, the size of the myocardium, a dilated heart, as the name suggests, the LV especially is dilated. The atria may be dilated, that is the left and the right atrium, but in these group of disorders, the left ventricle is the thing that's dilated. Okay, so that's what we call dilated cardiomyopathy. When you look at the chest X-ray, the chest X-ray is show evidence of cardiomegaly, especially the left ventricle, and we can do a session on chest X-ray to determine which side of the heart or which chambers enlarge, depending on what the chest X-ray looks like. But this is what a big heart looks like on the chest X-ray. And then echo, those of us who do echoes, when you measure the LV cavity size and diastole, it's dilated. So that's what a dilated cardiomyopathy. And then this is the pathological specimen. So the normal heart is on the right, and then a dilated cardiomyopathy heart with dilated chambers on the left. Now, what's the epidemiology and natural history of dilated cardiomyopathy? We look at heart failure as a group, and dilated cardiomyopathy is not much different from the heart failure as a group in terms of epidemiology. So symptomatic heart failure with dilated cardiomyopathy have a 25% mortality at 1 year, 50% mortality at 5 years. So you have seen these figures before. And the interesting thing, however, is that about 20 to 35% of patients with idiopathic dilated cardiomyopathy, that is, we initially don't know what's causing the dilated cardiomyopathy. About 20 to 35% of these patients have familial cardiomyopathy. So it's behooving on us to get a family history in these patients with dilated cardiomyopathy. So you have to get a family history, first degree family history, and you may have to do genetic screening. Not usual, but the recommendation is first degree relatives not known to be affected. They should undergo periodic serial echo screening with assessment of LV function and size. And you can do this every 3 to 5 years. And, genetic counseling, you know, if it's warranted. So basically, you should do a genetic family history. So delve into the family history a little bit. Now, endocrine and metabolic abnormalities can cause a dilated cardiomyopathy. Obesity. So you can get an obesity cardiomyopathy, and that is defined as a cardiomyopathy due entirely or predominantly to obesity. And we're talking about morbid obesity, not just regular obesity. Diabetes can give you a cardiomyopathy. If you remember clearly, diabetes was a risk factor for the development of heart failure. Um, and that is independent of age, hypertension, obesity, hypercholesterolemia, and coronary artery disease. So diabetes can give you a dilated cardiomyopathy. Thyroid disease. Now, you have hyperthyroidism and hypothyroidism. With hyperthyroidism tend to you can get a sustained tachycardia. You can get either sinus tachycardia or atrial fibrillation. And that in itself can give you a tachycardia-induced cardiomyopathy. Whenever you have a very high heart rate for a long period of time, that can weaken the heart muscle, give you a cardiomyopathy. So we think with hyperthyroidism, that's the mechanism there. But hypothyroidism, so a low functioning thyroid, you can get abnormalities in the systolic and diastolic blood pressure. You can get bradycardia, decreased ventricular filling, reduced myocardial contractility, diminished myocardial workload, a low cardiac output, and that can lead to a cardiomyopathy. Growth hormone, acromegaly, which is growth hormone excess, and even growth hormone deficiency can also give rise to a dilated cardiomyopathy. With growth hormone excess, the myocardium becomes thickened. It hypertrophies with interstitial fibrosis, and you get lymphomononuclear infiltration, death of the heart muscle cells, the myocytes. You get myocyte necrosis, death, and you can get biventricular hypertrophy. So both ventricles hypertrophy. Toxic cardiomyopathy. So toxic substance can give rise to a dilated a dilated heart with weakened heart muscle. Alcohol, alcohol is one of the most common um, condition you'll see that will give rise to dilated cardiomyopathy. So it's one of the most important cause. And you should try and identify alcohol as a cause of cardiomyopathy because if you catch it early, you can treat these patients, right? So it's most common in men aged 30 to 55 years of age. And they're usually heavy consumers of alcohol for over 10 years. Less common in female. So women represent about 14% of cases. Your risk of alcoholic cardiomyopathy will increase if you consume more than 90 grams of alcohol per day. And that translates into about 7 to 8 standard drinks per day for about 5 years. So that's excessive drinking. However, mild to moderate consumption of alcohol is protective against development of heart failure. But once you start drinking on a regular basis, it's difficult to lower your consumption, and most people sort of go overboard. So that's a problem. But mild to moderate consumption of alcohol is protective, and sometimes we do recommend this. And the recovery of LV function, that is after you stop drinking, the LV can repair itself and the ejection fraction gets back to normal. I've had a few patients like that. This is when you catch them early. If it's going on for some time, then the cardiomyopathy tends to be more permanent. What about cocaine? Cocaine can give you a cardiomyopathy. The long-term use may result in a dilated cardiomyopathy. What we found is that 14 to 18% of asymptomatic abusers have depressed LV function. So they have no symptoms. They've just been using cocaine for some time. Up to 18% of them will have depressed LV systolic function. And we're not sure, because when we have patients with heart failure, dilated cardiomyopathy, heart failure with reduced ejection fraction, beta blockers is one of our cornerstone in treatment. In these patients, we're not, some studies have shown that they can run into problem if you use beta blockers, so be careful about that. Cancer therapies. So we get a lot of referrals for patients going for chemotherapy, breast cancer, lung cancer, that type of thing, going for chemotherapy because they want to see what the LV systolic function is before starting therapy. And then sometime during and after therapy, you want to get an ejection fraction to see if the cancer therapy depress the LV systolic function. So anthracyclines tend to do that quite a bit, but also the monoclonal antibody Herceptin. So we get a lot of patients who is going to get Herceptin or they're on Herceptin. Other agents such as cyclophosphamide can do it. Toxoid, mitomycin, C, 5-fluorouracil, and interferon. So a lot of chemotherapy can cause a cardiomyopathy, so be wary about that. What about nutritional deficiencies? So nutritional deficiency is also a fairly common cause of a dilated cardiomyopathy. You can have primary and secondary deficiency. Thiamine deficiency, thiamine deficiency related cardiomyopathy, we think when you ingest alcohol on a chronic basis, that's the mechanism. Also, anorexia nervosa, AIDS, and pregnancy. We think these disease states can cause a thiamine deficiency and result in a cardiomyopathy. L-carnitine deficiency, L-carnitine is a cofactor in fatty acid oxidation, and that can give rise to skeletal myopathy and a cardiomyopathy. So problem with skeletal muscles and cardiac muscles. AIDS, acquired immunodeficiency. About 8% of asymptomatic HIV positive patients will have some amount of LV dysfunction. And some of these patients will develop heart failure. So, just HIV positivity in itself can give rise to a cardiomyopathy. Now, we had mentioned tachycardia-induced cardiomyopathy briefly when we talk about hyperthyroidism, but any type of sustained high heart rate can weaken the heart muscle, and I've seen it so many times. So always bear that in mind. Sinus tachycardia for a prolonged period can give rise to a cardiomyopathy. So you get an LV myocardial dysfunction, systolic dysfunction, that is, caused by increased ventricular rate. And this is reversible if you catch it early, of course. And I have a patient in particularly, she goes into AFib periodically. When she's not in AFib for a few months, ejection fraction 60%, she goes into AFib over a few weeks, her ejection fraction falls to 20%. So it's a real condition. Frequent PVCs can also induce a cardiomyopathy. And when we say frequent PVCs, this is usually over 10%. So, if you do your Holter monitor and PVC is 15%. Some people will treat it. We tend not to treat asymptomatic PVCs, but if it's a lot of them, because it can cause a cardiomyopathy, I will treat it. The mechanism is not well understood there. We use pacemaker quite a bit, but pacing at a high heart rate may also cause a cardiomyopathy. Some people say, well, why don't you pace the patient at a higher heart rate? Because they have they're going to have probably increased cardiac output and stuff, but that can give them a cardiomyopathy. So you have to be very careful about that. RV pacing alone can exacerbate. So with a normal pacemaker, that can cause heart failure to worsen and increase hospitalization and increase mortality. We have done studies that show that patients who have a pacemaker and doing well, their mortality is increased just because of the pacemaker. The heart was not meant to have hardware in it. So even though you'll do well because you have conduction system problem, over the long run it's not good. Chagas disease can cause a cardiomyopathy. In this side of the world, you probably don't know much about Chagas disease. If you're in Central and South America, you know about this because it's one of the more common cause of a dilated cardiomyopathy. It's caused by the parasite Trypanosoma cruzi. Okay, and again, Central and South America, people do an exam, they like these little things. With Chagas disease, cardiomyopathy, you tend to get a biventricular enlargement, so it's not purely left. You can get myocardial thinning or thickening, an apical aneurysm and sometimes thrombus. You can get clots inside there. So you'll get something looking like this, where the apex, there's a little aneurysm in the apex. Okay, so this is the pathological specimen showing aneurysm. So that's Chagas disease. And then on the echo, you can see the aneurysm as well. Okay, so apical aneurysm, you can get a dilated right and the left ventricle. The walls can be thickened. You'll get some amount of tricuspid regurgitation, mitral regurgitation, and when you look at the Doppler flow, you may get a restrictive filling pattern. You get a very small E prime, showing you that you have significant muscle disease. Chagas disease can also give rise to conduction system problems. You can get a right bundle branch block, left anterior fascicular block, and complete heart block requiring pacemaker. Okay. Inflammation-induced cardiomyopathy. So any type of hypersensitivity problem can give you hypersensitivity of the heart muscle. So you can get a hypersensitivity myocarditis. So if you have hypersensitivity to any variety of agent, that may give rise to the same thing in the myocardium. You'll get a peripheral eosinophilia, perivascular infiltration of the myocardium by eosinophil, lymphocytes, and histiocytes. So these are inflammatory cells. And common drugs that can give rise to this hypersensitivity myocarditis, sulfonamides, these are antibiotics, penicillin, streptomycin, blood pressure medicines such as methyl-dopal, hydrochlorothiazide, chlorothalidone, dobutamine, and then isoniazid, amphotericin B, tetanus toxin, and phenytoin. So these are common agents that can give rise to hypersensitivity thing. Rheumatological and connective tissue disorders, SLE, systemic lupus erythematosus, can also give rise to a dilated cardiomyopathy. You can get, with lupus, you can get pericarditis, you get some pericardial effusion. You can also get conduction system problem, complete heart block. And then when you look at the echo, you can see some evidence of cardiac involvement. Scleroderma, so it's another connective tissue disorder. It's rarely caused dilated cardiomyopathy, however, but you may have a normal, you may have normal LV dimensions or, fractional shortening, but subclinically the systolic function is abnormal, not very common. Rheumatoid arthritis, you can get a myocarditis, that's inflammation of the heart muscle, and you can get a pericarditis, inflammation of the pericardium. Dilated cardiomyopathy is rare in rheumatoid, however. You can get microvasculitis and microcirculatory problems. Now, this is a little bit more common, and you'll get this on your exam. Peripartum cardiomyopathy. So this is a pregnancy-induced cardiomyopathy. The exact cause is not known. We think it may be hemodynamic or immunologic. Well, what we know is that during the last trimester of pregnancy, you can get the LV systolic dysfunction, and then the early postpartum or in the puerperal period, after you deliver the baby up to about 6 months, you can get LV systolic dysfunction. It's not uncommon. It occurs in 1 in 1,300 to 1 in 1,400 live births. So people doing the exam needs to know that. What are some of the risk factors for peripartum cardiomyopathy? Advanced maternal age, older than 35, okay, going up. Multiparity, so multiple patients who have had a few pregnancies, increased risk. African descent, so blacks, more common in blacks, and then long-term tuberculosis. So if they had to stop the labor for whatever reason and prolong the labor period, then that's also a risk factor. What are the prognosis for peripartum cardiomyopathy? And that's related to the LV systolic function. So what type of LV systolic function you get will determine the prognosis. What we know is about 30 to 50% of patients have significant improvement in their systolic function 6 months after presentation. So up to about half of them, within 6 months, the systolic function improve. For those who do not have a recovery in their ejection fraction, then their prognosis is similar to that of any other dilated cardiomyopathy. However, subsequent pregnancy may be associated with further decrease in LV function. So you need to counsel these patients and tell them that if they're going to get pregnant again, it can result in another peripartum cardiomyopathy and sometimes worsening heart failure and death. So especially if the LV systolic function did not recover, that is a relative contraindication to pregnancy. They should not be allowed to become pregnant with counseling and medication and stuff like that, because they can die. If the ventricular function normalize, then the risk may be less, but they still have an increased chance of developing peripartum cardiomyopathy. Again, even it's going to be less than if the LV systolic function did not improve. They have an increased risk of venous thromboembolism, so you should think about anticoagulation, especially if the LV systolic function is very depressed and persistent. So we're going to move on now to iron overload. So this is also fairly common. So regular iron, the hemoglobin needs iron for its function. So we can get iron overload. And the thing about iron overload, you can get a systolic or a diastolic dysfunction. Okay, and it's caused by the increased deposition of iron in the heart. So the iron itself infiltrates the heart. There's a genetic disorder which we call primary hemochromatosis. It's one of them. But disease states such as the beta thalassemia major, because these patients require lifelong blood transfusion, and the blood is going to break down and it's going to release iron, and then the iron get deposited in the heart. So these patients have an increased risk of iron overload. Also, hereditary hemochromatosis. This is caused by an autosomal recessive disorder. This is one of the most common hereditary disorder of Northern Europeans, with a prevalence of about 5 per 1,000. The actual survival rates for persons who are homozygous for the hemochromatosis gene is about 95, 93, and 66% at 5, 10, and 20 years respectively. I mean, the important thing is that, you know, long-term, these patients don't do well. And we know that cardiac failure is one of the most frequent cause of death in thalassemia major because of the iron overload. These patients require multiple transfusions over their lifetime. Again, the red blood cells are going to break down. They're going to release the iron. The iron is going to be deposited in the heart muscle. Chelation therapy, these are therapy that can bind the iron, oral deferoxamine, or you can do simple phlebotomy, bleed out the patient, and that can reduce the iron overload and improve outcome. So we use MRI to look at these patients. So this, on top, you have a normal heart with normal iron, okay? Someone with a iron overload problem, you can see with a MRI, the myocardium is very dark, okay? So we can make that assessment. What about amyloidosis? Now, fairly common, is due to the deposition of insoluble proteins such as fibrils in the heart, and that can cause a heart failure. This is a specific type of dilated cardiomyopathy, and again, people doing an exam, you're definitely going to get some aspect of this, so you need to know it. You can have primary or AL amyloidosis, or you can have secondary amyloidosis. You can also have familial transthyretin amyloidosis, dialysis-associated amyloidosis, senile transthyretin was a wild type, and then cardiac involvement is primarily encountered in the AL and the transthyretin amyloidosis. And we recently have therapy for the transthyretin amyloidosis. I think that is approved this year, as a matter of fact. The mean survival with cardiac amyloidosis is less than 6 months. Okay? And we will sort of have an idea if the septal thickness on the echo is greater than 15 millimeters, if the ejection fraction is less than 40%, and then if the patient has symptoms of heart failure. Again, once you have all of these, the median survival is less than 6 months. There's a 3 to 4% of African Americans will carry an amyloidogenic allele of the human serum protein transthyretin des. So African Americans tend to carry the allele for that. There's an increased risk of cardiac amyloid deposition after the age of 65. Now, this is what they're going to give you in the exam, and you need to know you're going to get an echo. It's going to have a bright speckled appearance, okay, thickened. Again, remember septal thickening greater than 15 millimeters, but you're going to get this nice sort of speckled myocardium. You're going to get a small amount of pericardial effusion. The atria are going to be used, so they'll give you a 4 chamber to show you that the left atrium is big, The right atrium is big, and then they'll give you ECG. The purpose of the ECG is to show that the voltage is low. So you'll get thick muscles. You usually associate thick muscles with big voltage on the ECG. But if you get thick heart muscles, low voltage on the ECG, that's almost, probably 80% amyloidosis. And then again, big atria, the atria huge, a little bit of pericardial effusion. That clinches the diagnosis. What about sarcoidosis? Now, this is one of the underdiagnosed cause of dilated cardiomyopathy, and you know, you guys should search for this because it's out there. We're just missing it. Okay, so it's an underdiagnosed disease. It may affect as many as 25% of patients with systemic sarcoidosis. So a quarter of these patients will have some aspect of cardiac sarcoidosis. It may occur in isolation as well. So the presentation of patients with sarcoidosis having cardiac involvement, it may be asymptomatic. When you do your echo, they have LV systolic dysfunction. They may present with heart failure. They may have atrioventricular heart blocks. They may have atrioventricular arrhythmias, or they may present with sudden cardiac death. So if you make an assessment of cardiac sarcoidosis, the early use of high dose of steroid may halt, may stop, or reverse the cardiac damage. So if you make an assessment, and it's important to make that assessment, high dose steroid may be very helpful. And how we're going to make that assessment, we're going to use cardiac MR, that magnetic resonance, or PET scan. Again, people doing exams, this is how you do it. You don't do biopsy because sarcoidosis is a patchy disease. So you may biopsy an area and it may be clean, and the area next to it may be loaded with disease. So you don't do biopsies. Cardiac MR, magnetic resonance, or PET scan. Again, patchy areas of myocardial inflammation and fibrosis. So it's a patchy disease. If the patient presents with ventricular tachyarrhythmia or sudden cardiac death, you may need to put ICD in, implantable cardioverter defibrillator in. And this is what we mean by patchy disease. So this is a pathological specimen. You can see that it's not a uniform thing. Some areas look very clean. So you may biopsy the septum and nothing comes back, but the rest of the heart is loaded with sarcoid. Again, PET scan will help you. With PET scan, you have a metabolic portion and a perfusion portion. So PET scan is very helpful. MRI, again, so showing you the patchy nature of the disease. So in the exam, they want you guys to know that it's very patchy. You don't do biopsies, okay? So it's either your PET or your MR. What about stress cardiomyopathy, the so-called Takotsubo? So the broken heart syndrome, that's another name it goes by, and this is a real entity, stress cardiomyopathy. So the patient will develop acute reversible LV systolic dysfunction in the absence of any significant coronary artery disease. They may even present with chest pain. They may even present with ECG findings, okay? And it's usually triggered by some acute emotional or physical stress, and it's usually significant stress, okay? The classic finding is what we call apical ballooning, and you're going to get this in your exam, and they're going to show you a few things, and you have to get it right. So apical ballooning, okay, this is also another term that it goes by, apical ballooning cardiomyopathy. So you can get stress cardiomyopathy, Takotsubo cardiomyopathy, broken heart syndrome, apical ballooning syndrome. It was first described in Japan, okay? Often affects postmenopausal female. The majority of patients are going to present similar to if they were having a heart attack. So they will present with, of course, they can present with heart failure symptoms or chest pain. And the cardiac enzymes may be transiently elevated, not to the level as someone who is having a full-blown heart attack, but it can be elevated. But, you know, when you do your, this is one of the early picture. So when you do an LV gram, so this is a left ventricular gram cardiac cath, and you inject your dye in the LV, you get this apical ballooning. So in diastole, it balloons out, and it looks similar to this octopus pot in Japan, where the octopus goes in, and then they can't get out. So that's the Takotsubo. That's the octopus pot, and it looks when they did the categorization, they look similar. So that's how the name came about. But on echo, you get the apical balloon, and you can see the apex is big. Okay, the apex is big, and then the base is very narrow. And if you're a treating physician, one of the things you have to bear in mind is that, you know, because our real heart attack can give you the same picture. Anytime you have this apical balloon and hyperdynamic base of the heart, it can cause LVOT obstruction, and the patient, that in itself can, you know, can cause a patient can syncopize, or they can have heart failure, stuff like that. But apical ballooning, this so the stress cardiomyopathy is going to be an echo exam, it's going to be an all type of exams, so all the exams is going to be on. Okay, so again, when we do the cardiac catheterization, you get the apical ballooning with the left ventricular gram, and then when you shoot the coronaries, the blood vessels around the heart, there is no blockage. So there is no coronary artery disease to account for the wall motion abnormality. Okay, so we're going to stop here because this is enough, and then our next series of lecture we'll look at uh, the evaluation of these patients.